So I'm a fellow at the Nuffield Trust, and I work mostly on social care and integration. And I'll be talking to you today about integration in England, and sharing some reflections as well about kind of 20 years worth of integration of health and social care in England and the UK. And it's been a very long-standing policy intention. Thank you very much. So to talk to you a little bit briefly about how health and social care are organised in England. So health and long-term care services, or social care, in England are distinct, and they're subject to very different funding arrangements and accountabilities. So on the one hand, we have the National Health Service, through which all health services are delivered free at the point of use. And then kind of in parallel, we have long-term care services, which are subject to eligibility and means testing, and they're the responsibility of local authorities, and they're accountable to the local electorate. And so most health services are commissioned and planned at the level of integrated care systems, and these were formalised in 2022 and given a statutory basis. So local authorities do have a membership on ICS boards, on integrated care systems, but the ICSs themselves don't have social care responsibilities. So that kind of creates this little tension really between the kind of two parallel sides of the health and care system. And while the intention of the ICSs has been in part to improve the join up of local authorities and health services, these have largely ended up in as NHS integration bodies, so have been much more focused potentially around integrating better services between community and acute, for instance. So these current arrangements are really in their infancy, but there have been some early improvements. So for instance, around hospital discharge, which was a major focus in many areas of England. And worth noting as well that as part of this structure that we have at a kind of sub ICS level, we have place-based partnerships, which are local areas. So local areas have the flexibility to develop and shape according to their local priorities, as well as health and wellbeing boards, which align with local authority footprints. And just to give you an idea of scale, so our integrated care systems manage populations of about 1 to 2 million people, and place-based partnerships manage populations of about up to 100,000 people. So kind of a much smaller scale. I thought I'd share some of the learning and the reflections that we've had based on kind of 20 years worth of integration initiatives. And these reflections have come from research that we did that was published in 2021, and I can post the link in the chat if you're interested. This looks at 20 years worth of policies in England, and as well as the other countries of the UK, so Wales, Scotland and Northern Ireland, and the outcomes that these have sought to achieve. So perhaps we can as well talk in the discussion about some of the natural experiments of the UK, where we have 4 countries that operate very, very similar, but also quite different health and social care arrangements, and some of the learning that's come from this. So to start, I think a lot of the integration policy in England and across the UK has been set at a national level, so with some very top-down levers to support integration. So these have included things like pooling budgets, having structural reorganisations such as the development of the ICSs, as well as transformational funding. And I think while those have been able to deliver some improvements to joined up services at a local level, perhaps some of the levers that have been drawn upon have been a bit disjointed with what integration has been set out to achieve in policy. So a lot of national policy has had the expectation of improving population outcomes, creating efficiencies in savings, etc. And perhaps the levers that integration has enabled have perhaps not been quite so joined up with that. And I think that really lines up with what Stephanie was saying around the lack of a logic model around integration. Secondly, I think there's been an assumption at a national level that structural changes alone will be sufficient to overcome existing barriers, but the cultures are very different. So I was telling you a little bit about those two parallel systems between health and social care, or long-term care, and those accountabilities really are quite different. So local authorities are accountable to the electorate. They have to balance their budgets every year. The NHS is quite different to that, and it's accountable to NHS England. So it's the context in which they operate really vary quite considerably, and the structures on their own have not been sufficient to kind of address these cultural challenges. Then I think within ICSs, I think it's fair to say that in many cases, acute hospital trusts have still dominated, and it's been very difficult to shift funding flows away from the acute towards community health and social care, and especially in kind of current contexts of very high demand and pressure on across the entire system. And I think that's really limited the potential of the potential benefits of integration initiatives. Although there has been some more recent success, for instance, around hospital discharge pathways. And I think it's quite interesting that so one of the countries that we've looked at across the UK, Scotland, were intending to reform their integrated care structures to reintegrate around community and health and social care specifically and remove almost acute from the equation. These plans have been delayed, and I think it's quite interesting because really is that not just moving the decision about where the funding flows goes to more of a national level, so perhaps removing some of that local decision making. And then I think finally, one of the really big challenges that we've had about assessing the benefits of integration in England and the UK is that we've really struggled to measure the benefits of integrated care. So footprints have changed. So Stephanie referred to things like the vanguards and integrated care pioneers, which we've had kind of overlapping over a very short period of time. And I think the outcomes that national policymakers have hoped that integration can achieve are very difficult to quantify. In some cases, the data doesn't exist, or it doesn't exist in a way that we can really compare against counterfactual. You can't exclude confounders, so just natural improvements to population well-being. And I think as well, a really interesting thing that we found is that in some cases, integration might lead to some improvements, so identifying unmet need, but that might not necessarily lead to cost efficiencies because in fact, you're identifying a new population of people that were previously underserved. So I think it comes back to that point about having realistic objectives about what integration can achieve.